Here we go. Hi, everyone. Thank you for this culture change movement. You know, changing institutional culture does begin with language, and language costs no money, and you personally can decide what words you want to use or not use. And so I was asked to try to kind of create something to look at with some of the words we've been discussing. And so this is an encouragement, a challenge, an invitation to every one of you to consider the language that you use. And to be honest, there's sometimes maybe a pressure, like in the research field, at the university, in healthcare, at the nursing home. These are the words we use. And maybe you feel kind of a pressure to use the older institutional words that you're used to. And I just want to call that out and give you permission. There's power in language. And notice when we keep saying facility, the facility, the facility, what are we really saying? And perhaps we just keep perpetuating the old way, the institutional way. And so when you use different words like home, guess what? That's what we're trying to create. That is their home. Or a nice word is also community. Each nursing home in and unto itself is a community. In the culture change world, you won't hear what we kind of have fun calling the F word. It's up to you. Now, we also don't hear unit or ward. We try to even avoid floor. You know, this is an odd thing we say. I had to work the floor. Really? Were you vacuuming? You know, it's fun to think about what our words might mean. And instead of these older words, the medical words like unit, we have transitioned over to neighborhood. And if you think about it, because some people live there, guess what? They are actually neighbors to one another. In some homes, the people who live there actually have decided to refer to themselves as neighbors. And so you'll hear the director of nursing, the administrator say, well, the neighbors decided da-da-da. And it sounds a little awkward, perhaps, everyone, but one thing I've learned is to be honest, that is the word that describes who they are to one another living here. And it challenges us, what lens are you going to look through? Are you going to look through your professional lens and hold on to old words? Or are you going to help create a different culture and use the words that represent what's normal for the people who live there? So we're trying to not talk about the patients. Patients are usually in a hospital. They're not the people who live here. Guess what? We're even moving away from resident. It's fine to use it. Go ahead, especially if you need to move from patient. But we're actually thinking about what word is better. It's actually a person. Before we're people, before we're patients, right? The word individual, yay, it says exactly what we mean. They're an individual. Even the term rounding, where does it come from? The hospital. Physicians round because they don't work there. They're not there all the time. We don't have to use those words. In fact, many of us aren't. So we call it check-ins, sometimes checks. Sometimes these new words are kind of cumbersome, everybody. Be aware of that. Checking in with is how I say it, because it equals us. Check-ins with the person, adult to adult, versus checking on is even a big deal. And then we tend to use the word team instead of department. Next screen, please. I'm almost done. Something else to show you all regarding language. Look at this. We're going to go fast, whoever's doing it. Independent, what's it called? Living. Then someone needs assisted, what's it called? Keep going, living. And then you need more care, and what's it called? Long-term care. Look at this, guys. Where did the living go? Even out of the titles, the word living is missing. Go ahead, next slide, please. And then I want to challenge you, person-centered care. It sounds great, right? Go ahead, person-centered care. Keep going. Then that's old, by the way. Person-centered was old when CMS typed it 6 years ago in the new regs. Person-directed, we had already moved on to person-directed. However, we got a problem. Care, keep going, please. Resident-directed care, keep going. What's missing, everyone? Once again, what's missing is life and living. Go ahead. And so what we tend to do is talk about resident-directed life and living, or the next one is self-directed living. Isn't that cool? You and I are directing our life right now, and we're always going to want to. Is there another slide, or am I done? Last but not least, what lens do you look through? I challenge you to start looking more through the lens of the people who live there and it's their home versus your professional workplace.
it gives me great pleasure to introduce Kathy Owens, who is, and also Angela Will, who is clinical coordinator and HAI team at the Utah Department of Health. Kathy and Angela are going to be talking today about protecting residents.
Several topics prepared for you today. Our main focus is how do we protect our residents, our staff, our visitors, our residents' families, especially during COVID, and how do we stay resilient in doing so? So we're going to set the stage on that. We're going to introduce to you our Diamond Ridge Skilled Nursing and Rehab community, which serves as the basis of some of our case study questions. We'll spend the bulk of the presentation talking about key infection prevention and control measures. And we will provide an overview of those, but we will also give a little bit of detail about some key components of that. And we'll do some additional detail around safe visitation. Next slide, please. So first, let's set the stage. And I'm sorry, everyone, I've had a cold, so I'm got a little bit of a wonky voice today. But we want to set the stage and really just want to make sure everybody understands how to play from the same playbook in the pandemic of COVID in our world. We want to always stay on top of the latest guidance. We want to attend any calls that any of our agencies with whom we work provide to help us. And really the name of the game is communicate, communicate, communicate. Make sure you understand and communicate with your state survey agencies and definitely with your healthcare acquired infection teams. Angela is joining us today, and we're so excited to have you, Angela, with all of your voluminous expertise. You lead the HAI team in Utah, and we have benefited so greatly from these teams. Avalon has a presence in 6 states, but and including Utah. And Utah has just been such a wonderful partner for us, and in large part because of how communicable the state agencies have been and our HAI teams. We also recommend that you communicate with your state and local health departments or local health jurisdictions. They will have some additional guidance and may have some additional nuance to how to apply the regulations and the recommendations that come out of other agencies. And make sure you are documenting those discussions because it's really wonderful to be able to go back and refer to those. As you know, there's so much coming at once. It's hard to keep all the details straight. So that's just a little tip on making sure that everybody understands the baseline for everything that we're going to be discussing today. But you're probably asking at this point, how does infection prevention and control relate to resiliency during COVID? Well, we had some great presentations the last 2 weeks on resiliency. And doing some additional review of that, I found a nice summary article as well from the Mayo Clinics on resiliency. And I like their recommendation about learning from experience. You think about what we've been through with the COVID pandemic. We have been learning from experience. It's all been about lessons learned. We've been the petri dish of COVID, and it's been actually difficult, but interesting. And we together stay focused, and we do take our experience and learn from that and are better as we go forward. And then the principle of being proactive and following infection prevention and control basic core principles is being proactive. It provides a structure, and it helps us be able to integrate that into our daily work worlds. Now, it is a little tough to do this and keep that person-directed environment that Carmen so eloquently always refers to and keeps us on task around that, which I so appreciate. But the more you do the infection prevention and control, the more it becomes part of what you do, and it does integrate into the culture in the community. I also like to refer to the military adage of improvise, adapt, and overcome, because I think it really summarizes what we've done in large part also through the COVID pandemic, which is we're faced with a new challenge, we improvise, we figure out how to integrate that, and we overcome that challenge and move on to the next thing. So those are just some thoughts about how today's presentation does support resiliency. I'd like to now turn this over to Angela, who's going to introduce us to our case study focus. Angela?
Thanks, Kathy. As Kathy mentioned, I'm Angela Weil from the Utah HAI program. And I'm going to just kind of go over our example facility, which is Diamond Ridge. It's a fictitious facility. And as I discuss this, I want you to, in your minds, kind of keep in mind, what do you think would be the specific strengths, as well as some of the challenges that this facility might face in terms of their infection control. So this facility was built in 1975. They've got a mix of both short stay and long-term care beds. They have 10 of those rooms, which are private with private bath, and then the rest are semi-private with shared bathrooms. Their HVAC system is centralized. It can take up to a 10-rated MERV filter, which is changed out monthly. And they have hand sanitizer inside all of the rooms, as well as outside the entrances and in other areas of the facility as well. Facility leadership includes their admin, their director of nursing, and then the infection preventionist is also some things that you feel like they have in terms of strengths that would be advantages to them, and what are some of the challenges that they might need to be thinking about when they're developing their infection control program. The ideas that I had when looking at it is, of course, not all of the rooms are private, which of course, as I just see that mentioned, can be a challenge. Although I will point out that they do have some private rooms and not all facilities too. So that can be an advantage as well. One advantage that this facility does have is that they have ample hand sanitizer, as long as it's remained filled throughout the facility. Now, I imagine that soap and water is probably most likely only available in the resident bathroom, which especially with shared bathrooms can make it a little bit less accessible. And they also have, a good administrative team in place to help guide the facility. So these are just some things that are important to think about as you're building an infection control program. And one thing I saw ventilation mentioned, which definitely is not ideal in this facility. And you'll see at the bottom of the slide, there's a link. This facility would definitely be one that would want to look into some of the money that is available through CMS to purchase HEPA filters, air scrubbers, fans, and other components that they can use to improve the ventilation. In terms of what are the key components to build a successful infection prevention and control program. And as Kathy mentioned, we're really going to do a high-level overview. But an infection prevention program needs to have several components to be successful. Next slide. So first of all, you need someone to steer the ship, which is your infection preventionist. It's important that your staff all have the appropriate education and skills in order to do their job with infection control in mind. Vaccination is another key component. Screening everyone that comes into the facility, making sure that you have access to testing, good hand hygiene, your PPE, cleaning and disinfection, and physical distancing are all things that need to be taken into account to prevent infection and transmission in your facilities.
Okay, next slide, please. Thank you, Angela. That was really helpful. It's a great reminder. And it's easy to go through that list, right? But they are so each very critical into a successful infection prevention and control program. The first thing that Angela mentioned was that infection preventionist role. And wanted to just remind everyone, it is a regulation, F882, that states that we are required to have at least one person in each of our communities that is designated as the infection preventionist. And in fact, CMS, CDC, each recommend more than one person. And it really has served us well when we are able to have several people ready to step into that infection preventionist role and potentially shoulder the responsibilities of the role. CDC also recommends a full-time infection preventionist in those communities that have 100 or more residents or have a vent or hemodialysis program. That's not necessarily in the regulation. That is a recommendation from CDC. We are required to make sure that our infection preventionists complete specialized training. And we've included a link on this slide to the CDC training course for the infection prevention training. And it is free. There are a number of other courses that are out there. This one is free, but there are also some great ones through American Healthcare Association, ANAC, APIC, and there's a number of other state-based programs as well. This person needs to be working at least part-time in the community. That makes sure that they're very much in touch with what's really happening in the community. And they need to be an active participant in your community QAPI community. Next slide, please. And now let's go a little more detail into screening, because that's like our first gateway point, right? Of keeping our residents safe, keeping our staff safe, is to do that screening. And screening occurs for two major groups in our communities. The first is for any person that actually enters the facility. That would be employees, that would be anybody that meets that overall definition of staff that we have come to embrace as part of our CMS designations. It also addresses screening of our residents. So the screening process that is for anybody entering our facility usually does include temperature, COVID symptoms, COVID exposure, recent positive tests, or waiting for a test, vaccination status for all staff. We can ask that question of visitors, but it is optional for them to tell us. But if a person does fail any part of that screening, it should be elevated for additional review, and each community should have a process in place for that to occur, even off hours. And then we also, of course, complete a daily, at least a daily review or screen of our residents. And this would include a set of vital signs and a pulse oximeter and looking for COVID-related symptoms. But it's important to always note that we care for a highly vulnerable population. And they also, our geriatric residents frequently present with unusual clinical presentations for something like COVID, for infection. So we need to keep a high index of suspicion when we have our residents presenting with GI distress, falls, delirium. Those could all indicate an underlying COVID disease process occurring. And then you have the link to the guidance, super clear that you are responsible to go ahead and screen everyone who comes into your community. You're responsible for the results of those screening and that you're following.
So vaccination, of course, is one thing that has made a huge difference to our COVID response efforts. It's important your staff are now required to be vaccinated, and vaccination is also strongly encouraged for residents and visitors as well. It's not enough, of course, after you've completed that primary series and are fully vaccinated. You also need to then stay up to date with your vaccinations by getting boosters when it's recommended. And as a facility, having a vaccination program in place to make sure that you can provide ongoing vaccination to staff and to residents, and that you can document that is a critical piece of infection control. Next slide. Okay, so hand hygiene not only is critical for preventing COVID-19, but it's really a crucial process in any type of infectious disease prevention. Most of the time, an alcohol-based hand sanitizer is going to be the most convenient way to perform hand hygiene. But there's a few instances when you really need to make sure that staff are using soap and water. That is when either the hands or gloves are visibly soiled or have come in direct contact with infectious material, or any time that you're caring for somebody that has infectious diarrhea. Regardless of what method you use, it's important to use an appropriate technique. Either method, it takes about 20 seconds to sufficiently either lather or to cover the hands with hand sanitizer, and making sure that you're getting all parts of the hand as well as the nail beds when you perform that hand hygiene. With the soap and water, you would finish by rinsing and drying the hands. With the hand sanitizer, you need to let that dry on its own, not wipe it off or try to speed up that. Have a staff member who is caring for a resident after a high-risk exposure to COVID-19. And what we want to know is, when should this staff member...
Next concept as a way to think about how to apply the principles. Because as you know, as many of you may have experienced, there's a lot of guidance that we need to stay on top of. And sometimes it helps to sort of compartmentalize it into different categories. So as Angela has explained, vaccination is really important. And we've recently seen alliance between CMS and CDC on what vaccination up to date is versus not up to date. And that applies to healthcare personnel, residents, families, visitors, all of the groups. So we want to have as good a handle on that as we can. I know visitors sometimes is optional. We want to have an idea of what is the risk for severe disease. And we also want to pay attention to county transmission rates, because that may change and will change how we apply things like testing, PPE, physical distancing into the whole mix. As you'll recall, county transmission rate is 2 different data points that are considered, either the rate of positive tests in the community or the rate of number of cases per 100,000 residents in the community. And that means the community, like your county at large. So we've given you the link to the CDC COVID data tracker, and it is, I think we need to, thank you. Thank you. It updates daily, so it's an easy, quick reference tool for you. I've also included links to the critical documents, and we won't have time to go through all of these, but I have to tell you, I print these whenever they're updated, and I keep them close by wherever I am to be able to help answer the numerous questions that come up with how to manage COVID. So I would recommend you do the same. These are all very important links. There's more, but these are very timely, and I think you'll find that they'll get dog-eared like mine too. So next slide, and now Angela's going to take us into the use of PPE and some reminders in that regard. So Angela.
Thanks, Kathy. And what you can see here with this diagram from the CDC is this is an illustration of the types of PPE that you'll want to have available in your facility and what it looks like when somebody is wearing full PPE, either with a respirator, as you see on the left, which is recommended anytime you have someone with suspected or confirmed COVID-19, or some other types of precautions. You may need contact droplet precautions, and a face mask may be sufficient. You'll see that this PPE is worn so that there's no gaps between where the gloves end and the sleeves of the gown, that you could get droplets or infectious matter coming in, and all of the PPE is properly secured and in the correct position. Next slide. Another thing that is probably new to a lot of facilities that we did not see a lot before the pandemic is that you're now required to have a respiratory protection program. And a respiratory protection program makes it so that when staff use N95s or other type of respirators, that there's some critical components to have in place. The first is that there are some contraindications in people who really cannot safely use respirators. So it's important to conduct that screening and make sure that it's medically appropriate. It's important to conduct fit testing for the specific types of respirators that your facility carries. And if you change types of respirators, then you would need to redo fit testing. And then of course, also staff need to understand how to properly wear them, how to conduct those user seal checks, and make sure that they know how to protect themselves while they're wearing it.
Angela, could I interject here? I was wondering if you could address the question about whether or not the resident in the last poll question was vaccinated and whether that would make a difference and how that applies to PPE. And then I just encourage everyone else to look at the question that Cindy Prince put in chat. If you could share your experiences with what PPE you are using for admission isolations.
Yes,
Thank you.
of course. So with that resident, if they were not vaccinated, it would make a difference in terms of whether the resident would need to be quarantined and what type of PPE the staff would wear going into the room. If they're up to date, then you really only need to use the standard precautions, which are mask and possibly eye protection, depending on that county positivity rate. If they're not up to date, then they would need to be quarantined, and with that.
So I want to bring your attention to the document in the lower left-hand corner. There's a link to that as well. This was just updated on March 10th. It's QSO 2039, and it's the revised nursing home visitation guidance from CMS. And it has a lot of great information in it. It's one of those documents we recommend that you print and keep at your fingertips. So there's a couple of points to remember when we're thinking about safe visitation. We're thankfully being able to allow visitation. I think we all lived through the real challenges of not being able to do that. So I'm really excited we figured out a path forward for safe visitation. We do need to allow indoor visitation for our residents, for any residents who are permitted through the regulations to have someone come visit. So keep that in mind. But we need to make sure those visits are conducted in a way that keep in mind all of the infection prevention and control core principles that we've been reviewing. It is recommended that people wear a mask or face covering. And there is a little bit more information around that, so bear with me. It's recommended that the visitor wears a face mask or face coverings and physically distance during the visits, with especially when they're around other residents, healthcare personnel, etc. Once again, remember we talked about the county transmission rates. So if we have a low to moderate county transmission rate, it's still the safest practice is to wear a mask or facial covering and to physically distance. But it may not be as critical in the low to moderate county transmission rates. In substantial to high, however, it really is a requirement that our visitors wear a facial covering or mask. Once again, if there's a challenge with that, that would be a one-of situation that would need some very careful sorting through discussion. And that's one of the issues, quite frankly, that we raised to our HAI teams, as well as to local health jurisdictions to get some guidance on that. If we have a visitor that doesn't want to wear a mask and we want to make sure that we're following infection prevention and control processes. For practicing the physical distancing, we do want to make sure that we are attempting to provide physical distance, especially if it's during those peak hours when there's maybe a lot of visitors in the community. We want to protect their ability to physically distance safely. In terms of indoor versus outdoor visitation, outdoor is still the preferred method of visitation, but we do need to follow all the principles we've been talking about. If we do provide indoor or do have a situation that a resident and their visitor requests an indoor visitation, but we want to make sure as much as possible that we are protecting everyone. So if the roommate to the resident who's getting a visitor is not vaccinated, then it is recommended to not conduct that visitation in that resident room. Locate a different location in the community that will be able to accommodate that visit. And do remember to clean surfaces after you now. Amber is the evening supervisor at Diamond Ridge. She notices a visitor walking in the hallway and stopping by a resident's room to greet them. Which of the following should Amber answer? is thank the visitor for greeting the residents. Well, it's really nice, and I know everybody's been missing the other residents in the communities. I know when my mom was in a community, I got really close to a number of her friends that were in the community, and it's really hard to not visit with them. And but we do need to remind people we're trying to limit that contact. We're still in a COVID pandemic. We still are in potentially.
So as we come out of this, I know a lot of us would really love to just shut the door on the last 2 years and not look back. But I think that there are some real opportunities here, because I would suspect that every single one of us actually understands a lot more about infection control than we did a couple of years ago. And you've gained some really valuable tools that you can take forward and use for your facilities, so that not only are you more prepared in terms of what comes down the road for COVID, but any kind of infectious disease. A lot of the principles that you have learned in terms of COVID and controlling infection of COVID in your facilities are going to apply to any kind of outbreak or infectious disease, and make your facilities a safer place for all of the residents who live there, and make your facilities stronger.
That the unvaccinated staff who are not up to date with boosters should be wearing N95 masks. The goggles is unclear, and guidelines say yes. Our recent surveyor said it wasn't necessary. And so that's another example of why you really want to be familiar yourself with the guidance and the regulation. I believe it is in the CDC guidance that came out in January 21st on managing healthcare personnel with a risk or with SARS or with exposure, that eye protection is required in a substantial to high county transmission levels. But at the same time, we are encountering in a lot of jurisdictions that there's differing guidance. And so if you get differing guidance from any of your support agencies or your partner agencies, make sure you have that in writing and the rationale for it, just so that it's a great learning opportunity. And it just really makes it a lot cleaner if you do get challenged from a surveyor about why you.
It actually is a little bit complex. And so there's no strict requirement that unvaccinated or not up-to-date staff have to wear an N95 anytime that they're in the facility. What you do need to keep in mind is that if you look at what constitutes a higher risk exposure, if they do wind up coming in contact with a staff member or a resident who later does test positive, unless they are wearing an N95 and eye protection, then that would constitute a higher risk exposure that under conventional staffing guidelines would cause that person to have to be quarantined from work. So that is something that a lot of facilities do take into account, and in order to protect their workforce have made that a policy in their facility. With eye protection, it does depend if your community transmission rate is moderate or higher, then eye protection is recommended anytime that someone's providing care to.
Infection prevention and control is more critical than ever. When we all work together, we have a more successful program. So it's everyone's responsibility. And we can also stay resilient as we.
Last moments, we are going to go through the step 3 of the QAPI process, taking your QAPI pulse.
My name is Adrienne Butterwick. I'm a senior improvement advisor based here in Salt Lake City, Utah with CoMagin Health. Utah is one of the states that we serve in the Western region. And today I'm joined with my partner, Jean Lyon. She is a clinical care practitioner and senior infection prevention knowledge. That last week we had a wonderful presentation from our other QIO partner, Jean Rowland, and just appreciated her information on developing a deliberate approach to teamwork, and just wanted to make sure that we have a moment to reflect on what we learned last week and what we're going to be diving into this week. So if you have anything to share from that presentation, anything you took and implemented, maybe there you can share how you modified your approach to developing your team. or if you perhaps made any changes specifically maybe to include CNAs in your QAPI team, please feel free to put those in chat. We would love to hear that as we go forward. We just want to hear kind of how that information may have impacted you, and if you found anything to be of particular interest or that you've tried out here in the past week. Next slide. And I am talking fast. We're going to try to keep this right on time. So here is a list of our key elements of improvement. As I mentioned, we have talked about leadership in the first two series, and it really is an important foundation to the work that we do in quality improvement. However, as we know, there are many factors at play, and at times it can be difficult to know really where to focus your effort. Next slide. So a quick poll here, true or false? QAPI assessments should only be completed by an organizer. All excellent, excellent there. False. It really is, we want to include all members of the team, including QAPI committees, leadership, and front-end users. And this needs to be a true active teamwork. It really requires input from all areas of your organization. And this effort can really foster teamwork and support for buy-in and change efforts down the line, as well as promoting transparency. Next slide, please. All right, and I'm going to turn the time over to Jean to talk about our QAPI self-assessment tool. Go ahead.
Okay, Jean. Yeah. I hope I can talk half that fast. We are presenting a QAPI self-assessment tool today that actually was developed by CMS as part of the QAPI at a Glance, a step-by-step guide to implementing QAPI in your nursing home as a resource. This is just one example of a self-assessment tool that you can use. It's helpful to do a very thorough assessment of your facility. Sorry, facility is an out word now. Your your community. I'm a community health clinical specialist as well, so I still have difficulty with that. Anyway, to see where your starting place is in your nursing home. So the whole idea is to get a team together that's multifactorial, that you have representation from the entire community or in every neighborhood, and complete it with the input from the whole team, including nursing assistants and even residents. And you may find it helpful to add notes under each item as we show you the tool as to why you rated yourself a certain way. And then from that tool, because we know you have limited resources and limited time, you can then identify those areas that are the greatest risk for bad outcomes or never events. The other thing it does is to allow you to identify your OFEs, your opportunities for improvement. Okay, Adrienne, I'm turning it back to you.
Thank you. All right, here is a quick screenshot of that Appendix A on page 27. I just thought it would be nice to take a quick look at it. It's very user-friendly and easy to complete. As you can see, the tool really asks you to rate each statement by a not started, just starting, on our way, almost there, or doing great status. You can tally those and really identify some that really need that first look and priority, if you will. You know, and as Jean mentioned, we really do hear sometimes that this tool can seem daunting or pretty time intensive. It's 5 pages, there's 25 questions. They cover a wide range of topics, including culture, staff, resident, caregiver engagement, and the mechanics of your QAPI. So there are a lot of different areas that this assessment covers. So we may, it may be more helpful to take it in smaller bursts of time, really kind of taking it within the QAPI on the fly philosophy that we are employing here in our program, to just take a few questions either each time your QAPI meets, or even just going through a question within that first, one day, right? So you just have maybe a few minutes per day to really spend on your quality improvement or QAPI efforts. And maybe you just take it one question at a time, and then over time you've built it out. So there is really no wrong way to go about using this, but it is definitely very helpful to just help you keep everything on track and make sure that you're really addressing all the areas of a very high functioning QAPI program. Next slide, please. And this is just a deeper look at that tool itself. And I wanted to make sure that Jean had a moment to share any other question or any other comments about the assessment before we kind of wrap it up today.
Yeah, one of my favorite comments is something that in a previous ECHO presentation with several other states through the University of New Mexico. One of our colleagues who did the quality improvement piece always said, keep it simple. You must keep it simple. You cannot do your life's work in a month or 6 months. So it's very important that you do a thorough and honest evaluation as a self-assessment, and then design your QAPI plan and your PIPs, projects for improvement. Yes, Adrienne says, keep it simple, silly. Yes, that's exactly what she always said. Keep it simple, silly. I always just say, keep it simple, and take off little pieces for improvement, because that's the only way you can really tackle this. Otherwise, the whole premise of performance improvement and quality improvement is too overwhelming. Yes, Caroline is correct. Incremental change is good. And it's really all we have time and money for. You know, so you have to identify those highest priorities and work on those.
Exactly, those small tests of